Hi, my name is Ali and I'm an F2 working in Portsmouth. Today I'm going to talk to you guys about upper GI bleeds. This is a massive topic and we will go through it step by step and logically, but it's a very important topic to know for now, for exams, and for the rest of your career. So the main focus of this teaching is going to be on the two main causes of upper GI bleeds, or what I think is the most important: peptic ulcer disease and variceal bleeds. We will briefly touch on some other causes. Now, this is a detailed review. Extra information is included for those more keen. Um, I'm not saying you have to learn everything written down here. In fact, it's by no means a necessity at all, but it will help. So, when you're revising and doing oral examinations, it's always important to use classifications. For example, classifying investigations such as bedside, bloods, imaging, invasive. This will help you not only remember things for an exam, remember things on the ward, but you'll also sound more professional in an exam as well. So on the last two slides here, I've written like a guideline or a frame on how you can phrase your ABCDE. It's what I like to use myself. So instead of saying I would check respirate or whatever, you can say parameters I would look for in breathing would be respirate or saturations. Some examiners like it, some are indifferent to it. It's what I use. I'm not going to talk through them because it's just pointless, but find what works for you, memorize it well, and stick to it. So, peptic ulcer disease is a global problem. The epidemiology is written down here. It occurs in two locations: gastric ulcers in the stomach and duodenal ulcers. Duodenal ulcers are 4 times as common as gastric ulcers. Let's start with some definitions. It's important you know all your definitions smoothly. So, an ulcer is a break in the epithelial surface, and an erosion is a partial loss of mucosa. There's two different ways to differentiate between the two of these. One is based on size, so lesions greater than 5 millimeters and on OGD are typically called ulcers. If they're smaller, they are called erosions. In terms of histology, if there's a full thickness loss of mucosa, that's an ulcer. If there's preservation of the muscularis mucosae, then that is an erosion. This can be seen on the chart on the pictures here. So, how does peptic ulcer disease present? The main finding is abdominal pain. Now, it's a classic MCQ question on differentiating between gastric and duodenal ulcers. So if you think about it, there's a breach or a break in the epithelial surface. It's exposed and sensitive. When acid touches that, it'll generate pain. Now, if the ulcer is in the stomach, when you eat food, the pylorium at the end of the stomach constricts and keeps the food in the stomach for digestion. This means all the acid is being recycled in the stomach, and so gastric ulcers will be more exposed to the acid. So when you eat, the acid is kept in the stomach, gastric ulcers get more painful. When you eat, the pylorium is closed, the acid does not enter the duodenum, so duodenal ulcers pain is relieved. That makes sense. So, other symptoms: nausea, vomiting, dyspepsia, which is just indigestion, and bloating. A bleeding peptic ulcer presents with hematemesis or melena. Melena is black stool, which is the result of the digestion of hemoglobin in the red blood cells. So the causes of peptic ulcer disease. Remember, you classify everything. So infective causes: H. pylori. Less commonly viral infections. Inflammation, Crohn's disease, malignancy, gastric cancer, lung cancer, lymphoma. Medications, non-steroidals especially, steroids, and bisphosphonates. Other causes: Zollinger-Ellison, smoking, alcohol, stress. So in an exam, you might panic and think, if you remember these classifications, especially infection, inflammation, malignancy, it will help in any exam in almost any case. So H. pylori, Helicobacter pylori, is a gram-negative bacillus. It's transmitted via the fecal-oral route and is responsible for up to 90% of duodenal ulcers and around 70 to 80% of gastric ulcers. An important point for MCQs is that it's associated with the development of mucosa-associated lymphoid tissue lymphoma. You don't really need to know much more about that, except it's associated with chronic H. pylori infection. The pathogenesis of infection of H. pylori is a common and favorite exam question. So the factors lead to hypo or achlorhydria. It secretes urease. So this breaks down the urea into ammonia. As you know, ammonia is a base. This neutralizes the stomach acid, allowing H. pylori to survive and thrive. It secretes these two toxins, which cause inflammation and damage tissue. And finally, it has a flagella, which helps its mobility. So investigations. History and exam, you already know. Bloods, you look for full blood count and iron deficiency anemia, or a chronic immune thrombocytopenia, basically a microcytic anemia with low platelets. Infection markers are typically normal, sometimes slightly elevated CRP. Non-invasive testing is the presence of H. pylori antigen in the stool, the urea breath test, or H. pylori in the serum, urine, or oral samples. Invasive testing would be an OGD plus biopsy. Typically, several samples are used because the false negative rate is high. So, management, triple therapy, given for 2 weeks, high dose proton pump inhibitor, amoxicillin, and either clarithromycin or metronidazole. Initially, you start clarithromycin. If there's no improvement, you would switch it to metronidazole, and that's because antibiotic resistance is increasing in H. pylori. Quadruple therapy exists for pen allergic patients, and the regime is written down here. So, other causes. NSAIDs are the most commonly mentioned drugs in association with ulcers. So, how NSAIDs work is that they inhibit prostaglandin synthesis, and this is via their direct action on inhibiting the COX-1 enzyme. Prostaglandins are important in the stomach because they inhibit acid secretion and stimulate bicarbonate and mucus secretion. This then protects the gastric mucosa. So, if you have less prostaglandin, there's less protection from the gastric mucosa and more risk of ulcers. So, investigations for a patient you suspect has peptic ulcer disease. Now, this is different from the investigations to H. pylori slightly. This is just to see if there's presence of ulcers. H. pylori is to detect a bacteria causing ulcers. So, you do the full blood panel as usual. You can also send a serum gastrin if you're suspecting Zollinger-Ellison. Zollinger-Ellison is a gastrinoma, basically, so a tumor that secretes gastrin. H. pylori, you remember the investigations are on the other slide. Imaging, not very useful in peptic ulcer disease, but can exclude other potential causes such as obstruction or perforation or complications of peptic ulcer disease. Invasive would be OGD, which is the gold standard. The ulcers can be directly visualized and biopsies taken. So these are the nice guidelines for OGD. Simple, just 3 bullet points. Any urgent OGD should be done in a patient with new onset dysphagia if they're over the age of 55 with weight loss and one of either upper abdo pain, reflux, or dyspepsia. And also if there's a new onset dyspepsia which is not responding to proton pump inhibitor therapy. Treatment for peptic ulcer disease is specifically targeted to treating the underlying cause. In general, you would start with conservative management. This would be to stop smoking, reduce alcohol intake, and lose weight. Medical management would be to reduce acid secretion. This can either be done with proton pump inhibitors or histamine 2 receptor antagonists. There are elective surgical procedures, although the medical management is quite successful. These include vagotomy, so one or several branches of the vagus nerve is cut. This can either be truncal or selective. You could do an antrectomy with vagotomy, so the distal half of the stomach, the antrum, is resected and the vagus nerve cut. Surgery, however, is most frequently saved for complications. So, in an exam, you'd say management for peptic ulcer disease is specifically targeted towards the underlying cause, for example, H. pylori, stopping offending medications such as NSAIDs. In general, conservative management would include reducing alcohol intake, stopping smoking, and losing weight. Medical management is focused on reducing acid secretion, and this can be done with a combination of proton pump inhibitors or histamine 2 receptor antagonists. Finally, surgical procedures include dissection of the vagus nerve or resection of the stomach in severe cases. Now, peptic ulcer disease is very important because if poorly managed, it can lead to several complications, the most important of which are upper GI bleed or perforation. Right, so earlier we talked about investigating peptic ulcer disease electively. In an emergency setting, the priorities are different. So, history and exam, there's a classic triad of a perforated peptic ulcer, which is sudden onset abdominal pain, abdominal rigidity, so peritonism, and tachycardia. You want to do a PR exam to see if there's any melena, a fresh bleed, or an empty rectum. In terms of blood, it's similar, except you'd include a clotting in case they need an operation, or if there to see if there's any coagulopathy causing a bleed. You'd also send a lactate and an amylase to exclude other causes of an acute abdomen. In terms of imaging, you want to do an erect chest X-ray to see if there's any pneumoperitoneum or air under the hemidiaphragm. Abdo X-ray is less reliable. You can do a barium swallow, which would show contrast leakage from the perforated ulcer, but the gold standard and hence in bold is a CT abdomen with contrast. In surgical investigations, exploratory laparotomy are less common now, but it's important to mention them as a last stage. An interesting point is in some rural centers, what they can do is once they insert an NG tube is that they inflate air via the NG tube and repeat the chest X-ray to see if the pneumoperitoneum has expanded. Now, this isn't done anymore, but it's important. It's just interesting to know about. Perforated duodenal ulcer, or a PERF-DU, is one of the most common and important causes of the acute abdomen. It typically affects the first part of the duodenum. As you know, there are four parts. Classically, it's described as if it perforates anteriorly, it causes a pneumoperitoneum, and if it perforates posteriorly, it causes hemorrhage. And this is because there's a vessel called the gastroduodenal artery which lies in close relation with the posterior part of the first part of the duodenum. Now, it's also important and interesting to know that the second, third, and fourth parts of the duodenum are retroperitoneal. So if they perforate, then you would not get the classic chest X-ray finding of a pneumoperitoneum. Right, so management of a perforated peptic ulcer. Any management of any condition in an emergency situation begins with resuscitation. So you'd say, now resuscitate this patient based on the ALS ABCDE guidelines and talk through each step. Once the examiner is happy, you'd say initial management would begin with conservative treatment. So not all perf ulcers require surgery. Some studies say as high as 80% can be managed and recover and heal with conservative management. What is conservative management? So NG tube with suction, very important. IV antibiotics to cover for anaerobics as well, so metronidazole, and then IV fluids, and most importantly is repeat clinical assessments to ensure there's no deterioration. Anyone can say fluids, antibiotics, and NG, but a repeat assessment makes you stand out. So surgical management. Most perforated peptic ulcers are managed with omental patch repair. So basically, a part of the omentum is just sewn on to cover the defect. I'm not sure how that started originally, but it's quite a good idea. If the ulcer is very large, if there's uncontrolled hemorrhage, or if there's cancer suspected, then a partial gastrectomy can be performed as well. If there's a bleeding duodenal ulcer, so this is relevant to an upper GI bleed, this is managed with underrunning of the ulcer. So, to summarize peptic ulcer disease, numerous causes, you know to classify them. Infection, H. pylori, medication, NSAIDs, those are the most common. There's a logical stepwise management ladder, both in an elective setting or in an emergency setting from its complications. The two most important complications to know about are hemorrhage, normally from a posterior duodenal ulcer, or perforation. Last line. So, ABCD is key. Learn your ABCD techniques word for word so you don't miss things, but don't make it sound too long as to bore the examiners and your vivas. Remember, all management begins with resuscitation, and then you go into your steps. Classify everything, and you'll be grand. I hope this wasn't too long or boring for you. If you do have any questions at all, please feel free to email me, and I'll get back to you as soon as I can.